So I call the talk Carriers Do Count, because I'm sure you've all had that experience. Oh, you're just a carrier. Well, carriers don't get sick. Carriers don't have this. Carriers don't have that. But we all know that that certainly is not the case. Very briefly, you all know what hemophilia is, X-linked recessive disorder. If you're deficient in clotting factor 8, you have hemophilia A, which is far more common. If you're deficient in factor 9, you have hemophilia B. And you see the difference in the incidence, 1 in every 5 to 7,000 live male births for hemophilia A, 1 in every 25 to 30,000 live male births for hemophilia B. And we grade the severity of the hemophilias by the percent of clotting factor that can be measured in the blood. And normal is 50 to 150%, but we can talk a little bit about that. The severes make no detectable factor less than 1%, moderates 1 to 5%, and milds 5 to 50%. And the definition of mild, it depends on who you read. Some places are saying 5 to 40%, and then 40 to 50% is near normal. But in general, if you're under 50%, over 5%, under 50%, you fall into the mild category. And it's the severes who have gotten a lot of attention. And those are the people who are diagnosed in the newborn period or a month of age. Those are the people who are likely to have severe life or limb-threatening bleeding spontaneously. Moderates, 1 to 5%, are diagnosed a little bit older, usually because they're developing bruising, even if they're not particularly mobile at that stage. And those people with 1 to 5% are less likely to have spontaneous bleeding, but certainly will bleed when provoked with trauma or with surgery. And the milds we may never see, at least with hemophilia A, that 5 to 50%, in this slide says 60 to 30%. These people are picked up later, and they may not be picked up at all unless they go for a surgical procedure and the screening shows that it's a prolonged PTT, and then they get referred to a hematologist. Or they have had a surgery or dental extraction and they're bleeding a lot, and they get back to see me that way. Most of the bleeds with hemophilia are associated with joints. 10 to 20% are soft tissue bleeds, muscle bleeds, and 5 to 10% are considered to be life-threatening, which would be intracranial bleeding, neck and throat, and also significant GI bleeding. When we form a clot, 3 things happen all at the same time. The blood vessel, which is torn, tries to close on its own, doesn't do much, but starts the ball rolling. The platelets, the little sticky pieces of cells like Velcro, are directed to the break in the lining of the blood vessel, and they stick to each other and they stick to the lining. And by doing so, they make what's called a primary platelet plug. Why is this doing it by itself? Go back. Okay. That platelet plug, as you can see in the electron micrograph, is very fragile. It's very lacy. There are gaps and spaces between it. So something has to happen to fill in those gaps to make the clot tight. Now, this slide is showing you the blood vessel. There's the platelets jumping up. The big von Willebrand protein is very important for attracting the platelets and also for attracting the clotting factors. And ultimately, you end up with the clotting factors coming that way and forming fibrin, which is the glue or cement that fills in the cracks between the platelets and makes the clot tight. You're probably familiar with the screening tests, right? So this is the clotting cascade. It's measured 2 different pathways that funnel into the common pathway. And you can see where the factors come into play. When we're talking hemophilia, both factor 8 and factor 9 are found in the intrinsic pathway, which is measured by the PTT. Factor 7 is found in the extrinsic pathway, which is the PT, and then 10, 5, 2, and 1 are all in the common pathway. But in general, one of the basic tests that we rely on to at least start our thought processes going is the PTT. Depends on the lab, depends on the reagents used, but in general, if you've got a PTT that tells you that it's taking this person's blood more than 34, 35 seconds to form a clot in the test tube, that's kind of a little red flag. You really need to start looking at the clotting factors that are involved in that pathway. Again, preaching to the choir here. About 1 million women and girls in the United States have a bleeding disorder, but probably only about 20 or 25,000 know about it. What are the most common reasons that a woman goes to see a healthcare provider? Well, pregnancy, for sure. But the other two things are either heavy menstrual bleeding or iron deficiency anemia. 20 to 30% of women with heavy menstrual bleeding may turn out to have an undiagnosed bleeding disorder. And 15 to 25% of women with iron deficiency anemia may turn out to have an undiagnosed bleeding disorder. That's a lot of people. And these are very common complaints. I mean, go to, if you were to ask your gynecologist, how many people have you seen in the last month who came to you because their periods were heavy, you'd be surprised by how many that is. And in our emergency room, we have girls coming in, they don't know anything about anything except that all of a sudden they passed out in school. Turns out that they have a hemoglobin, a red cell count of 5 or 6 instead of 12. And they've been having periods that last 7 days, 10 days, 12 days, and they're just bleeding and bleeding and bleeding. And they turn out to have von Willebrand's disease or factor 7 or something else. So I was really excited to hear about that petition. When this is done, I'm going on to sign. I texted my 2 daughters also. I said, sign, because there's a very clear knowledge gap. There is a definite need for a better understanding of how a bleeding disorder impacts the health of affected women, regardless of what their underlying diagnosis is. And it's taken a very long time. And it's taken a long time for the medical establishment to accept the reality that women do have bleeding disorders and that women can have hemophilia. And there are other bleeding disorders besides that, besides von Willebrand's. Most of the work to date, however, has focused on the hemophilia carriers. A delay in diagnosis of a bleeding disorder is a common problem. This is a great article if you guys like to read medical articles. It's called Sexism in the Management of Bleeding Disorders. And again, technology is not my friend. And it was written by Dr. Wayand, who's talking in the next room. It's a lack of knowledge that women have bleeding disorders. The focus in the world and in the medical establishment has been on men and hemophilia. There have been far fewer resources for women and girls until recently. And there's a real lack of awareness that carriers can bleed. Again, like I started out by saying, technically, if you're a carrier of an autosomal recessive disorder, you may not know anything. You're not going to have any symptoms. You're not going to have any problems. It's different with hemophilia. And we're going to talk a little bit about that as well. How can somebody genetically be a carrier for hemophilia but have no symptoms? But yet, the next woman who is genetically a carrier can have symptoms. And this is called the lion hypothesis or skewed X inactivation, and we'll talk about that a little bit more. There's a spontaneous mutation rate of about 30% for hemophilia. In general, the classical inheritance is that the mother is carrying the gene. She got it from her father, who was a hemophiliac, and she passed it on to her sons. Hemophilia is carried on, both 8 and 9 are carried on the X chromosome. Women have 2 X chromosomes, men only have 1. Therefore, if a male has a hemophilia gene on his 1 X chromosome, he is going to manifest hemophilia. But a woman, because she has 2 X chromosomes, may or may not manifest symptoms. And this just shows you what happens with the inheritance. Dad is not affected, mom is a carrier. Anytime she conceives, that hemophilia gene has a 50-50 chance of going to that child. So any male she conceives has a 50-50 chance of having hemophilia or not. Any female she conceives has a 50-50 chance of being a carrier. Now, what about the other way? Dad has hemophilia, Mom is fine. Mom is not a carrier. This is the very typical scenario, right? Dad only has one X chromosome to give, and that X chromosome has the hemophilia gene on it. Therefore, by definition, all of his daughters will have the hemophilia gene. All of his daughters will be carriers, whether they're symptomatic or they're not. And none of his sons will have hemophilia because they're getting the X chromosome from the mother who is not affected. In 1951, there was a report that 47% of carrier females reported oozing following dental extraction. And how did they know they were carriers? These were in all likelihood, given that this was 1951, they had hemophilic sons. So 47% of carriers reported oozing following a dental extraction, unusual bleeding. And then in 1986, the observation was that there's a lot of variation in factor VIII between major labs. And today, there's a lot of questioning about how are you measuring that factor VIII? Are you measuring it with a one-stage assay, which most hospitals have? What about a chromogenic assay, which is a two-step process? Is that more specific? Is it better? When do you use it? So 40 years ago, it was noted that the levels seem to be bouncing around depending on what lab you use. And today we're trying to fine tune to get the most accurate levels we can. This was published in 1956, a laboratory study of the carrier state in classical hemophilia, 1956. And the summation was, from both the sociologic and medical points of view, it would be important to detect those females who are conductors of the genetic defect. Now, back in those days, it is very likely that it was important to be able to counsel these women about the risk of having a hemophilic child in terms of managing her own health issues. I'm not sure how robust that was back in those days. I would tend to think that, oh, you have heavy periods. Well, of course, you're a woman. Oh, you have iron deficiency. Well, yes, of course, you're bleeding every month. So that was sort of the mindset back. So the strict definition of a carrier is an individual who has a disease-causing change in one copy of a gene, but does not have the genetic disease itself. So this is a genetic diagnosis. That's the way you confirm if someone is or is not a carrier. An obligate hemophilia carrier is a daughter of a man with hemophilia, as we saw. A mother who has two sons with hemophilia, because while there's a 30% spontaneous mutation rate, as the old saying goes, lightning doesn't strike twice in the same place at random. So a mother of two sons with hemophilia is by definition an obligate carrier. A mother of a male with hemophilia who has another male relative with hemophilia, like her father or her brother or a cousin or an uncle. What about a possible hemophilia carrier? Well, a daughter of a female hemophilia carrier may be a carrier, and we saw from the previous slide that a carrier woman who has a daughter has a 50-50 chance of that daughter inheriting the hemophilia gene. A mother of a male with hemophilia, but no family history of a bleeding disorder, well, that boy may be the index case, right? The 30% spontaneous mutation showing up right then and there. A female relative of a male with hemophilia, a sister, a mother, and many of you may have participated in the My Life, Our Future initiative and other genetic initiatives where sisters and mothers and even aunts on the maternal side are genetically tested to see if they could be a carrier, because the implication is so important for the women, for your health, not just the potential for having a hemophilic child. Some of you may remember community counts. population profile, back in, you're participating in that now. Prior to that, there was something called the Universal Data Collection, and that ran from 2012 through 2020. And we enrolled men and women, and at the end of that time, there were 33,000 males who were enrolled and 22,000 women. And you can see that there were a lot of women with hemophilia A. Fewer women with hemophilia B, but that's because hemophilia B is so much less common in the population anyway. So the statisticians got to work, and they figured out that for every diagnosed male, there are about 3 females in his family who are likely at risk for being a carrier. And it turned out in that study that for every diagnosed male, they identified more or less 1 to 2 genetic carriers were identified. So again, the carrier is a genetic designation. It is not a clinical diagnosis. And hemophilia carriers have a very wide distribution of factor VIII and factor IX levels. They can even have normal levels and minimal bleeding or no unusual bleeding. And you can see here, here's your factor VIII or factor IX level, and here's the number of subjects. And look at the overlap between the factor VIII, factor IX levels of carriers and non-carriers. So the number alone doesn't necessarily give you a clue unless it's definitely low. If you've got a woman who's got 52%, 54%, and she has a hemophilic son, you don't know. You can't say to her, yeah, I know for sure that you're a carrier based on your factor level. We have to do more. We categorize women now as we do the men. We don't say, oh, you're a symptomatic carrier. That was a terminology even 30 years ago. You're either an asymptomatic carrier or you're a symptomatic carrier. And it turned out that if you called women asymptomatic carriers or symptomatic carriers, as long as you threw the word carrier in there, a lot of insurance companies were not going to cover their medical care. Why? Because carriers don't have the disease. So we've changed the vocabulary, and we've recognized that if a woman has 35% factor VIII or factor IX level, she has mild hemophilia, same as if she were male. If you have a woman with 3% factor VIII or factor IX, she's a moderate hemophiliac, and there are women who are severe. We are pushing as a community of treaters to change the terminology. Instead of saying just carrier, asymptomatic, or even mild hemophilia, make it specific. A heterozygous, which means 1 normal X and 1 hemophilia X, heterozygous X-linked genetic carrier is the precise way to go about doing that. I don't think that's ever going to fly, but technically speaking, that's what it is. So when we talk about women who are carriers who may or may not have symptoms, what does that mean? So this is a cat who's black and orange, and in cats, fur color is carried on the X chromosome. So you can see in this cat the areas where there's a lot of orange fur. She happens to have all of her X chromosomes in the cells in that area are the ones that are coding for orange fur. And in the black fur area, her cells are the X chromosome is coding for black. Because women have 2 X chromosomes, we don't need to have both of them up and running full tilt to go on about our existence. It's redundant. It's too much genetic material that would be active. So during our embryonic life, if we are female, in every cell in our body, 1 X chromosome is shut off at random. And this is called the lion hypothesis or lionization. So think about, that's what's going on with this cat, right? So in some areas, by chance, most of his orange fur X chromosomes were shut off, and therefore the area was black. In other areas, most of the black fur X chromosomes were shut off, leaving him with the orange X's, and therefore that patch of fur is orange. And this just kind of shows you in a human form. Here's a woman who has all of her, there's all of her X chromosomes. Now, what if many of them were shut off and they were the hemophilia chromosomes? So the tan ones here, okay? So this is a woman who is not going, her X chromosomes that say don't make a lot of factor 8, don't make a lot of factor 9 are shut off. She is going to have her normal X chromosome up and running. She's going to have normal factor levels. She's going to have normal periods. She's not going to have unusual surgical bleeding. And she may not know that she's a carrier until she has a hemophilic son. Now, if you look at a woman like this, and now think about shutting off most of the normal X chromosomes, that woman will be functioning with the X chromosome that says don't make a lot of factor 8 or factor 9. That's the woman who's going to have low factor levels. That's the woman who's going to have heavy periods, unusual surgical bleeding. So that's why it's called skewed X inactivation, because it's random. And you don't know how many of the hemophilia X's are going to be shut off and how many of the normal ones are. It's totally random. It's skewed. But that's why when we are counseling a new family and there's no family history, we are very careful to explain to the mother that she could be carrying the gene, and we have to do more testing on her. Now, if she says, you know, I have periods that last 10 days, I've been treated with intravenous iron 6 times, I had a tooth pulled and I bled for days, and you go ahead and you get her PTT and it's 50 seconds, and you go ahead and you get her factor 8 or her factor 9 and it's 12%, you pretty much have an answer. But women may bleed, and I'm not talking menstrual bleeding, which is a whole other ballgame, but women may have unusual bleeding or bruising at sufficiently high factor levels that if they were male, they wouldn't have any issues. So there's a lot we don't know. So again, unless the percent of activity of the factor is low and definitely low, you really have to go further. You really have to get that genetic testing. And like I say, so the screening is the PTT. It's variable. It's dependent on what reagents are used, how old are the reagents, and it's not always really accurate. Factor activity. Factor 8 is interesting because in anyone who makes any amount of factor 8, the factor 8 protein is very small. And if something doesn't happen to stabilize it as it goes through the circulation, it's going to get wiped out. So the factor 8 lives its life attached to that big von Willebrand's protein, which protects it and which extends the time for the factor 8 in circulation. But we don't need all that stuff floating around all the time in our bloodstream unless we're bleeding. So the factor 8 and the von Willebrands that live together, a lot of that is stored in the cells that line the blood vessels. And during stressful situations, as part of that fight or flight response, the factor 8 von Willebrand's protein is dumped into the circulation so it can get to work. Kind of makes sense, right? If you're injured, you're fighting, you want to have all hands on deck to either control or prevent bleeding. But the factor 8 level can vary due to any kind of stress. It can be the kid who doesn't want to get poked running around the waiting room. It can be the teenager who knows that she's going to die because she came to the hematology oncology clinic and she sees the kids who are getting chemo and she knows that there's something very, very wrong with her. So she's sitting there as nervous as can be. Maybe somebody's been sick. Fever is a stress. Diarrhea, hyperthyroidism. Interestingly, pregnancy and birth control pills also raise the levels of factor 8. That's why women who are mild hemophiliacs during pregnancy won't have any problems because their levels are already up. So we can't necessarily buy into the factor 8 level. We may need to repeat it more than once. Factor 9 activity is pretty stable. And everybody is born factor 9 deficient, but by the time we're 6 months old, if we are not hemophilia Bs, our liver has matured and our levels have come up to normal. And once you're at that point, the factor 9 level really just doesn't change much during life. Genetic testing can be expensive, and for reasons which escape me still, some insurance carriers will not cover it. If you know the genetic change or the mutation that exists in the family, it's less expensive because then you can tell the lab, only look for this. And it's like $250, $300. But if you don't know the mutation and the lab has to do the whole factor 8 gene, it can be upwards of $1,200. And again, that My Life, Our Future initiative, which ended in 2017, was free gene sequencing for possible carriers of both hemophilia A or B. And over 11,000 women were enrolled. They identified in the first 3,000 women 285 previously unknown pathogenic mutations. So this was a very important thing. I keep waiting for it to come back. When should you test? Well, you definitely want to know if a woman is a carrier or not before she gets pregnant. That would be the ideal situation, because then she and her husband can make whatever decisions they may want to make in terms of wanting to carry a pregnancy with a hemophiliac to term, not wanting to, only wanting to have girls. I mean, it's a whole area of reproductive options and health, which is a very personal decision. But it also plays into how do we deliver this woman. I now have a woman, I know she's a genetic carrier for hemophilia. She happens to have normal levels, so I'm not worried about her during the pregnancy any more than I would worry about anybody else. But she's carrying a boy. And I need to be concerned about whether this baby is or is not affected. And we'll talk a little bit more about that at the end of the talk. A lot of mothers say, well, I want my daughter tested before her first period. That's fine. Because again, you don't know if a girl is a carrier, if the girl's a mild hemophiliac, and you want to be able to troubleshoot her menses. You don't really want that surprise of having, a 4-week period right out of the box, and then, 2 weeks later she's bleeding again and everything else. It's very helpful for our families to know, to get the girls tested, usually 9, 10, so that we know when she's going to get her period, what we have to look out for, what we need to teach them to look out for. Certainly, if you don't know a woman's carrier status or a girl's carrier status, and she's going to be having a surgical procedure with a high risk of bleeding, like tonsillectomy and adenoidectomy in kids, right? Wisdom teeth extractions, it is good to know what her status is, what her factor level is, and also whether or not she's a carrier, so that you can proceed to plan for the surgery as well. Again, the factor 8 or factor 9 levels in women are not good predictors of bleeding. You would think that they would be more or less the same way they are in men, but with the exception of women who are truly severe hemophiliacs and have no detectable factor 8, we've had girls who have 3-4% levels and they really don't bleed unusually. We've had girls who had 44% levels and they bleed like crazy. So the level, the number itself is not going to guide you as much as it does with the guys. And this just goes into what are some of the riskier moments for women in terms of controlling bleeding if they are mild hemophiliacs or what used to be called symptomatic carriers. Certainly small wound bleeding is a big deal. Joint bleeds occur in carrier women, and surgical bleeding is a big deal. Many people want to know when they go to, particularly when they go to a new healthcare provider, what questions should I be asked? And it's, if you know that you have a diagnosis, then certainly you go into your new doctor, your new nurse practitioner, and you say, this is what I have, these are my factor levels, this is the kind of bleeding I have, I'm being taken care of by. But if you're being referred to somebody for the first time, or you don't know if you are a carrier or not, and you present yourself to a hematologist or to any kind of a healthcare provider, there needs to be what we call a bleeding history done. And this is something that we teach the interns and the residents and the fellows at our institution from the moment they basically walk in the door. They get sick of hearing it, and I don't really care. This is built into our electronic medical record as well. You want to get a sense for a bleeding pattern, a bleeding history. And it's not enough to ask somebody, have you ever had a nosebleed? Yeah, a couple of times. Okay, thank you very much. Tell me about your periods. Are they heavy? Are they good? Everybody in the world has heavy periods, but there are very specific ways of asking those questions to be able to discern whether or not somebody is actually potentially dealing with an undiagnosed bleeding disorder. So this is a very simple bleeding history. These things are also called BATs, or bleeding assessment tools. And you can look them up online. There's a whole bunch of them, and getting more and more specific. How many times, did you need cautery for a nosebleed? That sort of thing, to get more and more specific, because the more specific you get, the higher your score, the more likely you are dealing with an underlying bleeding disorder. So this screening tool, which is very simple, which is why we kind of like it, because it doesn't take that long and our interns and residents can do it fairly easily. It's considered positive, meaning I got to look further. If a woman reports that her periods last at least 7 days, she floods or bleeds through a pad or tampon in 2 hours or less, she passes clots the size of a grape, she floods the bed, she stains her clothing. Also considered positive if there's a history of treatment for anemia, and that can be little kids too. We've had a number of kids with bad nosebleeds, and they're low in iron, and it turns out that they have a bleeding disorder. If there's a family history of a diagnosed bleeding disorder, absolutely. If the woman has a history of excessive bleeding with tooth extraction, delivery, miscarriage, or surgery. And I like to phrase it with, when you had your tooth extracted, was your oral surgeon worried about the amount of bleeding you were doing? Because people are understandably concerned when they're bleeding. And it can be difficult for a lay person, especially the person who's having the issue, to be able to say, oh yes, this was a lot, or no, it wasn't. So I kind of turn it back to the surgeon, which is also what I ask a surgeon when one of my kids is going to be having a procedure. And I don't care what procedure it is, and I don't care how often I've asked the question, because our role should be to take this patient with an underlying bleeding disorder or a bleeding tendency and get them through the surgery so that they don't bleed any more than someone who isn't affected. So I have to rely on the surgeon telling me when he or she thinks there's going to be a lot of bleeding, what does he or she expect? And that's why this question going back to the patient is, so was your oral surgeon worried about the amount of bleeding you were doing? Was your gynecologist worried about that? Was your ENT surgeon worried about it? And this just supports what I had said before. using the bleeding assessment tool, the higher the number, the more likely you're dealing with a bleeding history. So in normal women going through one of these bleeding assessment questionnaires, here you can see that, their score was 1, and in hemophilia carriers, it was up to 5. The higher the score, the more likely you're going to be dealing with something. The pictorial bleeding assessment chart is specific for menstrual periods. And there's a picture of it later on, but basically we give this to all of our girls in the girls' clinic. It's a graph with pictures of pads or tampons. We give them a red pen and we ask them to, for each day of their period, draw in what their pad or tampon looks like. Is it completely red? Is it just a few spots? And then we score it that way as well. So not a surprise. Again, the higher the number in the pictorial bleeding assessment, the more likely you are to be dealing with a bleeding disorder. There's a difference between hemophilia A carriers and women who are not affected. And these are individual bleeding symptoms from one study in hemophilia A carriers. Again, the orange are normal women. Look at the difference across the board in terms of bleeding symptoms that are far more common in hemophilia A carriers than in women who are not affected. This also presents a similar information, looking at other aspects of things, number of bleeding events, and do they have to use birth control pills for managing menses? Most of these are much more common in hemophilia A carriers. And when you talk about a history of anemia, I really wonder how many of these normal women are undiagnosed and consider themselves not to have a bleeding disorder. Same sort of a picture with hemophilia B carriers, with much greater incidence of a number of different types of bleeding: heavy menstrual bleeding, postpartum bleeding, surgical bleeding, cutaneous bruising. What's interesting is that the hallmark of hemophilic bleeding is the joint bleed, right? That's what we work very hard with prophylaxis to prevent. Everything is about joint health. And in this particular survey, no women who were not affected did not report joint bleeds. Hemarthrosis is a real thing in carrier women, and it may be very subtle. It may not be the big swollen knee or ankle that you may be used to from taking care of a male with hemophilia. A very common story that I get from mothers of hemophilics, when, oh no, I don't have anything, and my father never had anything. I'll ask specifically, did you used to jog or run track or play tennis in college and high school? And so many times I get the answer, yeah, but my ankles would kill me when I walked off the court. Or I had such bad shin splints, I had to give up my athletic scholarship to college because I could no longer run track. Start to do the workup, and you find out that these are women who are mild hemophiliacs. And when we look at their joints with ultrasound, we see changes which are consistent with having had hemarthrosis. So women most definitely can get joint bleeds. It's unusual for them to be spontaneous, but with provocation, like sports, like, walking a lot or whatever, yeah, they are. And they will have issues with their joints at factor levels where a guy doesn't. And part of that is a physics problem, because women are built differently. We carry most of our weight lower down. Our knees are built differently from men's knees. They move differently. So the stresses that are being placed on our joints as females are different from the stresses that males are putting on their joints just by their natural anatomy and physiology. So it stands to reason that women may be biologically more likely to sustain some degree of joint damage, just because of all the different stresses that our bodies place on our joints. people ask, is there a correlation between the mutation that is found and the likelihood of having symptoms? And in males, the nonsense mutations and the intron 22 inversions are very common with severe hemophiliacs. And there has been some work to suggest that if those are the familial mutations, then that woman may be more likely as a carrier to have symptoms than if there are other types of mutations that are the familial mutations. So what do you do if you want to have a baby? Well, women who are at risk for being carriers should have their carrier status determined, ideally before they become pregnant. And we've talked about who makes an obligate carrier, and obviously if the factor level is inconclusive, especially if a woman is already pregnant when she comes to our clinic to determine if she's a carrier, again, the estrogens are going to bump up her factor 8, not factor 9, but the factor 8 is going to be bumped up. We do some talking. We have a gynecologist for the adults who's very involved and very open and knowledgeable. And we have our pediatric adolescent gynecologist. So we talk about in a very non-judgmental way, because this is extremely personal. Usually the door is opened by the families, but it's like, these are the things that can be done so that you have a heads up in terms of the potential for your baby, if it's a male, to have hemophilia, or if it's a girl to be a carrier. Certainly ultrasounds, everybody's getting ultrasounds 12 ways come Sunday during their pregnancies these days. And if you are lucky and you get a crotch shot, then you are pretty good about knowing whether it's a boy or a girl. What they're doing now is something called free fetal DNA, which is done in the first trimester. And there's always a little bit of backwash of fetal blood into the maternal circulation, and they're able to identify the fetal blood and can measure things like factor 8. And increasingly now, if the familial mutation is known, there's a real push to get that done with the free fetal DNA. It's not there yet, but hopefully it's just going to be something that if you have that genetic information, they can add it on to the probe of genetic markers that they're doing. Pre-implantation genetic diagnosis requires the couple to be going through IVF. And obviously you can certainly find out these things on an amniocentesis or chorionic villus sampling, but these are invasive and they carry a small risk of fetal loss just from the procedure. So again, a lot of talking, and not so much with us, but with a gynecologist or a high-risk OB. It really is important for women who are carriers or women who may be carriers who are pregnant with a boy and we don't know the boy's status to really consider how to protect this baby, because you don't know if he's a hemophiliac. The standard recommendation is if a woman is a carrier or there's a likelihood she's a carrier and she's carrying a boy, the optimal mode of delivery is a cesarean section. Now, hemophiliacs have been born vaginally for decades and centuries, but there is a higher risk of intracranial hemorrhage in an infant who is a severe hemophiliac. And doing a cesarean section avoids a lot of that risk. Now, many women are like, no, I had 3 kids already. I never had a problem. I had them all vaginally. No, I'm not going to do it. So then the discussion is, okay, we don't know what this baby's status is. We want to protect the baby. So if it seems as if your labor is not progressing smoothly and the OB is making suggestions about vacuum extraction or forceps, that's drawing the line, because that can definitely cause an intracranial hemorrhage in an affected baby. And as soon as one of my moms tells me that she's pregnant, I'm on the phone with the gynecologist. I'm on the phone with the nurse practitioner. I'm on the phone with the hospital they're going to be delivered at, if they're not going to be delivered at ours, so that labor and delivery knows. And we talk to the mom and say, look, okay, fine. If there's no other reason for you to have a cesarean section, just be aware that you're not going to be able to deliver vaginally if there's instrumentation involved. And I haven't had problems with that at all in terms of arguments. We also try to avoid fetal scalp monitoring during labor. A lot of times, or fetal blood draws from the scalp while the baby is down in the birth canal. Again, you don't want to precipitate a bleed. The most important thing would be for this woman to deliver in a facility where there's blood banking, where there's a hematologist, where there's a pharmacy that can get factor if need be. And this is not a plan that can come to fruition when she calls you on the way into the delivery room. Guess what, Dr. Davis? I'm going to have the baby. What baby? So again, it's a lot of communication. There's a lot of planning from our end in terms of the baby that has to go on. We do cord blood testing. If the woman hasn't had access to free fetal DNA, and they know the familial mutation and that sort of thing, then we do cord blood testing. And that involves the cooperation of the obstetrician, so that when he or she is collecting, they collect a number of tubes of blood in the delivery room. They get a light blue top tube and they send it to our coag lab, so that by the end of the day, if not sooner, we know the baby's factor level. And we do this for the boys. We don't do it for the girls. And it's unusual for a female carrier, even a baby, to really have an issue at the time of delivery, because the maternal hormones have passed into the baby anyway. And that's going to raise her levels of factor 8 anyway. Factor 9 is another story. But again, girls most often will be found to be in the mild range. And since girls are not going to undergo things like circumcision in the newborn period, it's the sort of thing that we usually will do cord blood on the boys. Dr. Sidonio, who Janet referenced, came up with this in 2014. I remember him at NHF doing this and just corralling women to come and do a range of motion of their joints, because he believed, which is true, as we found out, that women who are factor 8 or 9 deficient will have reduced joint range of motion. And this ties into identifying through ultrasound and physical therapy exams that they may well have been having joint bleeds. His key findings, and he corralled 368 women with factor 8 and 158 with factor 9, and they had all been enrolled in this universal data collection. And I remember in those days, we had the physical therapist there doing the range of motion and the measurements. And I remember him at NHF sitting there and just grabbing people and saying, hey, let me examine your joints. But he found with this study that as the factor 8 and 9 activity decreased, the overall joint range of motion also decreased. And in most cases was significantly lower than controls. And this just shows you, here's a normal study. This is the mean range of motion. This is the age of the women. Now, we all know as we get older, our range of motion deteriorates anyway. But look at the difference between the decline in range of motion in patients who have normal factor 8 or 9. And this is just a prototype normal study. It's pretty close to that. Women with mild deficiency definitely have a lower range of motion throughout the age spectrum than women who are not affected. Moderate deficiency, even more so, and severe deficiency definitely impacts the range of motion. And this just shows you what we can see on ultrasound in a woman who is a carrier for hemophilia who has joint issues. We can pick up, and many of you may be familiar with the point of care ultrasound now, if your HTC has it. And certainly we use it a lot on our boys and our men, but we've started a study looking specifically at carrier women as well. And this arrow points to a heaped up area of hemosiderin, which is the denatured blood, basically. You don't get that in a joint unless there's been a bleed. And as I said, we have a carrier ultrasound project. I'm trying to push for one for women over 40. Right now, it's 18 to 40 years old. And we have documented carriers, either hemophilia A or hemophilia B, between 18 and 40, and they get a physical therapy exam, and they get their knees and their ankles and their shoulders and their hips examined. And we're finding that there are subclinical changes. I want to push for over 40 because I think it's going to be important to see if you can see progression of changes, which if you were dealing with a male would be attributed to hemophilic arthropathy rather than the joint changes that occur with age. So far, that hasn't happened. What about quality of life? That's a big deal, right? Well, in general, for women who are found to be carriers, low energy and fatigue is a very big impact on quality of life. And again, stands to reason if you're iron deficient because your periods are off the wall, you're definitely going to be tired and have low energy. And I think one thing that we tend to forget is that women who are carriers are caring for men who are affected or boys who are affected. So women in general, we kind of tend to not take very good care of ourselves because we're too busy taking care of everybody else. But I think it's a real issue for the hemophilia carriers because they may be putting their own bleeding issues aside because they have to deal with their son or their husband or their father or somebody like that. Pain and overall general health as well are two areas where the quality of life for a carrier is significantly less than for an unaffected woman. I'm not going to necessarily go into management because we're going to run out of time, but there are definitely protocols in place for managing surgical procedures. Again, we want to make sure that our patients are bleeding just like everybody else. That depends on your factor level. Maybe it does require infusions of factor. If Stymate ever comes back to the marketplace easily, then our hemophilia A carriers may benefit from that. Antifibrinolytics like tranexamic acid or Lystida or Amicar may be useful for stabilizing clots in places like the throat and the GI tract. In general, if a woman is symptomatic or mild hemophiliac and has a level less than 50%, we really need to start to think about using factor concentrate in a surgical setting. If the woman has a baseline factor level of over 50%, and we know she's a carrier, then it depends on the nature of the surgery. And a lot of the times we may start with Amicar or tranexamic acid, but we always have factor on standby. And menorrhagia affects about 90% of women with an underlying bleeding disorder. It affects about 70% of women taking an anticoagulant. And it's a real public health issue. 50% of the hysterectomies done in the 1990s turned out to be done in women with an undiagnosed bleeding disorder. So we have come a long way because we're not seeing that occurrence of hysterectomies, at least not in places that have an HTC, but it's a real risk. It's a real public health issue. Women having hysterectomies during their reproductive years because nobody could figure out how to manage their terrible periods. And many of these women were not done having families. The high healthcare costs, the poor quality of life, it just continues to reverberate and to ricochet around. impacting the whole family, impacting the woman's job, impacting her productivity in the workforce, impacting her kids. So it's a real issue. And this just gives you what is a normal menstrual period, basically less than 7 days, and maybe using no more than 6 pads or tampons per cycle. So maybe 1 or 2 changes a day. But if you have heavy menstrual bleeding, you're bleeding for more than 7 days at a clip, you're actually losing 80 milliliters of blood per menstrual cycle. And there were people who collected used pads and tampons and wrung the blood out of it. So that's a pretty accurate statistic. Today, there's the menstrual cup, so you can actually measure the blood volume from that. Also predictive are clots over an inch, which is like the size of a grape, history of iron deficiency anemia, history of transfusion because of heavy periods, changing a pad or a tampon every hour. And this is that pictorial blood assessment chart that I was telling you about. Gives our kids something to do, and it's very helpful information because after they are put on some kind of a regimen to improve their period, they come back in 3 months and we give it to them again and see how it's different. So this is more within the realm of the gynecology people in terms of how do you manage a woman with heavy menstrual bleeding. And if she's considering pregnancy, then you avoid IUDs, you avoid oral contraceptives, you avoid the patches. But if she's not considering pregnancy, if she's considering pregnancy, you want to avoid the birth control pills, you want to avoid the IUDs. You want to go with things which are going to stabilize the clots, which would be tranexamic acid or Amicar, maybe factor. There's a risk of postpartum hemorrhage in women who are carriers because even in the women who are factor VIII and the estrogens have bumped that level up, within 2 to 3 days of the baby being delivered, that level of factor VIII falls. And this goes along with the von Willebrand women also, and they can then start to really bleed. So we get the adult hematology team involved when one of our moms is having a delivery, because certainly for a cesarean section going into it, factor has to be used. If they want to use an epidural for anesthesia, you have to give factor. But assuming it's a normal spontaneous vaginal delivery and she went into it with an 80% factor VIII level, we watch really carefully and then really jump in day 2, day 3, to make sure that there isn't going to be postpartum bleeding. And this graph just shows you what happens to factor VIII levels during pregnancy, and that's the solid gray. And you see factor IX levels really don't change very much. And this just talks about postpartum hemorrhage and how much bleeding you can have with a woman who is a carrier. You can lose 300, 400, 500 milliliters of blood postpartum, and that really becomes a medical and a life-threatening emergency. So, comprehensive care, hemophilia treatment centers. We grew up in the 1970s taking care of men and boys, and we have now expanded tremendously. So what can your HTC do for you? Well, women's programs, for sure. We can educate your primary care providers about women with bleeding disorders. You can educate your primary care providers. We like to work in partnership with our patients. Getting involved with the Hemophilia Treatment Center allows for better use of medical resources. Definitely prenatal care, pregnancy and delivery plan. And of course, access to all of the different healthcare providers who are involved with comprehensive care. We coordinate surgeries for our carrier women. We co-manage the heavy menstrual bleeding for our teens and for our adult women with our GYN colleagues as well. So I thank you. I hope you guys got something out of it. And I really, it's a really positive thing for me to be able to take care of the teenagers and the women that I am taking care of now. So thank you.
Thank you, Dr. Davis. We do have a couple questions that showed up in chat. The first one is real brief. Does factor VIII increase with age?
To a certain extent. Now, if you're a severe, it's not going to increase. We see that the von Willebrand's protein level goes up with age. It doesn't make you not have von Willebrand's disease, but you can have a subtle increase in factor VIII as you get older. It's usually not enough to make a difference in terms of your bleeding pattern.
Okay. And then we have one other, and then I'll open it up in case anybody wants to verbally ask any questions. And I'll read it. I'm not sure I really understand it fully. It says, my daughter was diagnosed as a factor VIII carrier based on having the same mutation as me, and I never understood that. I do have a severe factor VIII son.
Okay. So whatever your son's mutation is, you had genetic testing done, and they identified the same mutation in you, and then because you have, go down, sweetheart. Because you have, I told you, and we're back. Because you have a daughter, she was appropriately tested, and she was found to have that same mutation. So your son and you and your daughter all have the same mutation. Now, why is he a severe and you're not? And I don't know what your factor level is. I don't know if your daughter has any bleeding symptoms, but remember, your son only has one X chromosome. So if he got your hemophilia X chromosome, he has hemophilia. And the genetic change in him would most likely be one of those that is affiliated with severe hemophilia in males. You and your daughter have two X chromosomes. Go back to our black and orange cat. We don't know how many of your hemophilia genes were shut off during your embryonic life. We don't know how many of her hemophilic genes were shut off during embryonic life. So it's very possible, because of this random inactivation of one of the X chromosomes, it's possible that you may have a higher baseline factor level than she does. You may have no symptoms, but yet she does, or vice versa. So that's the mutation is in the family. And as your daughter gets older, this is going to inform some of her family decisions as well. Did that answer your question?
My daughter, who is now 54, has chosen to not have any children based upon that carrier detection test, but mostly based upon her brother getting HIV from his blood transfusions when he was 13.
Right.
And after going through that and seeing her brother with all the trauma that he went through as a severe factor VIII, she has chosen not to. And because my son acquired HIV, he could not have any children either. So I have no grandchildren. And I am the epitome of your talk. I'm 74 years old. I am in so much pain, I'd rather die than live.
Oh,
And
I'm sorry.
I am the only woman at my treatment center. I have been told such things as, you don't have real hemophilia. These are the kind of things I have heard and lived with, along with the pain and the disbelief that we can have joint pain and damage.
Absolutely.
And what can I take for it? You know what? There's very few drugs that I can take for my pain, and it's out of control with the pain. And I'm the only one I am. I wish your talk would be given to every treatment center in the country, because I am what you're talking about. but I'm at the far end of it. I was one of the participants in the study
Mhm.
in 1973. My factor level was 18% at that time.
Mhm.
And I've lived what you're talking about.
Yeah.
Every step of the way I have lived.
Wow.
And I don't want to anymore because there's no control of the pain. And every joint is damaged. Every joint, shoulders, hands, and every surgical procedure ended up in more surgical procedures. Just what you're saying. And nosebleeds, everything was discounted. As a teenager with bad periods, who was I going to compare myself to? Who could I talk to?
Right.
Who cared? I didn't even know. And I've had the postpartum. You know, I could write a book about what you have just said in this entire presentation. And this should be a must in every treatment center.
Well, I agree with you. Not just every treatment center, but in all honesty, I think things like public health clinics, mobile clinics. I mean, this is what we've been trying to do, is to get the word out, even if it means nobody knows what they're doing. Pick up the phone and call. Here's my phone number. Pick up the phone, call the treatment center, and let's see what we can do if you're concerned about a patient. But unless you know what to look out for, like you said, people aren't. I am so sorry that you've had that journey. I must say, that's just.
I have 2 daughters with mild hemophilia,
Okay.
5 and 10. And side note, I want to thank you for your contributions, just living in this world horrifically and helping to progress things for my daughters. So thank you so much for that. But Dr. Davis, going back to you were talking about girls doing tennis and cross country, things like that. My daughters are in competitive cheerleading, and they've never had any issues.
Okay.
Knock on wood. But you're talking about getting scans and whatnot. I'm wondering, should I have them see if they can get like a baseline scan?
What are their, I mean, what are their factor levels?
So my oldest, they're right around 40. One's a few
All right.
above, one's a few below. So
the reality is that when they're all hyped up, so they're pretty close to the normal range. They're definitely mild, but when they're cheering and they're doing all that stuff, their adrenaline is going, so they're jacking their levels up anyway. Okay. Now, a general recommendation, and I would be to have them at least have a physical therapy evaluation, because I'm not necessarily with the ultrasound or anything like that, but you're obviously hooked in with the Pediatric Hemophilia Treatment Center, I would assume.
Yeah, I go to Indiana, so we're pretty good
got
shape.
Everything. I think what we tend to do is we have a dedicated pediatric physical therapist, and when any of our kids are getting involved with sports of any kind, she does a whole physical therapy evaluation on them, and she can offer suggestions for either exercise or conditioning or whatever that may lessen their risk of having a joint issue from that sport. I mean, I find that fascinating. I mean, she'll just sit there and, well, now you should really warm up this way, do what your coach says, but you should do this too, because that sort of thing. So I think that's probably the 5-year-old. I'm not quite sure how aggressive 5-year-old cheerleading
Not
is.
too much, not yet.
Not too much. Yeah, she probably is much more aggressive playing around with her friends. But the 10-year-old is starting to get there, right? And I think that to me it makes sense to just get that kind of an evaluation going and open that conversation, because I can tell you that what Kelly ends up doing is she'll see the kids who are involved with sports, they're home on spring break or something. She'll come by the gym. Let's make sure that, you're doing stuff the right way, type of thing. It establishes a relationship as well, which can only be beneficial to them.
Okay, great. Thank you so much.
No. Thank you guys for having me.